Good morning. This is Ron Valdiserri. I would like to welcome all of you to our webinar today on World Hepatitis Day. If I can have the first slide, please. There we go. We're really excited to have all of you join us for this very important presentation on perinatal hepatitis B and C transmission. My name is Ron Valdiserri. I'm a co-chair at HepVu, and I will be serving as the moderator for this call, this webinar. Next slide, please. We are delighted to have two outstanding presenters. Dr. Catherine Chappell, who is a professor of medicine in the Department of Obstetrics and Gynecology at the University of Pittsburgh. Catherine's going to be speaking to perinatal hepatitis C. And we also have Ms. Julie Lazaroff, who is the unit chief of the Perinatal Hepatitis B Prevention Unit at the New York City Department of Health. And Julie will be speaking to the prevention of perinatal hepatitis B transmission. What we're going to do is hear from both of our speakers, and at the end of the presentation, as time permits, we'll take questions from the audience. Next slide, please. Of course, this webinar is being made possible under the auspices of HepVu. I hope that all of you on the webinar know about HepVu. If you don't, by all means, visit our website. It is a partnership between Gilead Sciences and the Rollins School of Public Health at Emory University. And HepVu strives to make data on viral hepatitis in the United States widely available so that it can inform public health practice and public health policy and decision-making. In addition to various maps with surveillance data, we also have a number of very interesting blogs from a variety of different people. We have, for instance, today we are hearing from Jim McCrae, who's in charge of HRSA's Bureau of Primary Healthcare, and Jim's talking about what steps community health centers have taken to address viral hepatitis in the United States. So by all means, visit the website and definitely get on our listserv. Next slide, please. Well, all of you joining this call are aware of the fact that in order to eliminate viral hepatitis in the United States, we really have to eliminate the perinatal transmission of both hepatitis B and hepatitis C. And that's what we're going to be talking about today, the steps that can be taken to achieve that very, very important goal. Next slide, please. And it hasn't missed our attention that we're having this webinar on World Hepatitis Day. And granted, I think all of us who have our roots in public health and clinical medicine and any kind of social service activity recognize tremendous need to address the ongoing pandemic of SARS-CoV-2. But at the same time, we must not ignore or forget the importance of eliminating hepatitis, viral hepatitis in the United States. And that's the theme this year of the World Health Organization's World Hepatitis Day is hepatitis can't wait. We really have to move forward. Next slide, please. And with that, I'm going to turn it over to Dr. Catherine Chappell, who's going to speak to perinatal hepatitis C transmission. Catherine.
Thank you so much to HepVu and to Ron for that introduction and to allow me to talk about a topic that's so near and dear to my heart. I want to first start with a punchline, is that unlike for hepatitis B, currently for hepatitis C, there is nothing that we can actively do to prevent perinatal transmission. However, with the revolution of hepatitis C treatment, the advent of direct-acting antivirals, there's a significant opportunity to reduce perinatal hepatitis C transmission, but we first have to evaluate if these antivirals are safe to give in pregnant women. Next slide. So these are the objectives. First, I'm going to review the prevalence of hepatitis C among pregnant women and women of childbearing age, and really look at the association between the opioid epidemic. We're going to discuss the epidemiology of maternal to child transmission of hepatitis C, describe the current and recently changed hepatitis C screening recommendations for pregnant women, and identify strategies that we currently use to prevent perinatal transmission, although I mentioned none of these are very active strategies, and then to describe the current status of the research regarding hepatitis C treatment during pregnancy. Next slide. So these are data of the newly reported chronic hepatitis C cases in 2018. What I want to draw your attention to is that currently, and these trends hold to today, is that we've seen an overshadowing of hepatitis C prevalence among young persons of reproductive age, overshadowing those of the baby boomer generation. And this is due to the increased prevalence of hepatitis C due to the opioid epidemic. Next slide. And if we were going to overlay the hotspots of the opioid epidemic over those of maternal hepatitis C infection, we would see that they are essentially the same, with a significant hotspot in Appalachia, which includes my area in Western Pennsylvania, where at my hospital, we have approximately between 1% and 2% prevalence of hepatitis C among women delivering at my hospital. Next slide. So who are these pregnant women with hepatitis C? So they are predominantly non-Hispanic white women. They are less likely to be married, less likely to have over high school education, more likely to have Medicaid for their insurance, more likely to have a history of preterm birth, to smoke cigarettes, and less likely to have prenatal care. And as you can see, from 2009 to 2017, really the population of non-Hispanic white women has really increased as far as hepatitis C prevalence. Hepatitis C in pregnancy is associated with an increased risk of gestational diabetes, cholestasis of pregnancy, and cholestasis of pregnancy is associated with an increased risk of stillbirth and also preterm birth. Next slide. So one of the most significant consequences of the increasing prevalence of hepatitis C due to the opioid epidemic is the risk of perinatal hepatitis C transmission. So what is the rate of perinatal hepatitis C infection? For women with just hepatitis C infection, the risk of transmission is about 6%, and it's double that for women with co-infection with HIV. What are the risk factors for maternal to child transmission? It's anything that increases the blood exchange between the mom and the fetus. So prolonged rupture of membranes, obstetric or intrapartum procedures or events that lead to infant exposure of maternal hepatitis C infected blood. That includes internal fetal scalp electrode monitoring, vaginal lacerations, operative delivery. In addition, there's been a noted risk of perinatal transmission with active maternal drug use. Next slide. So until very recently, hepatitis C screening in pregnancy was risk factor based, meaning only pregnant women with risk factors for hepatitis C, so like known injection drug use or history of an organ transplant a long time ago, would be screened for hepatitis C. However, starting in 2018, there came this call to action of universal screening of hepatitis C, meaning every pregnant woman should be screened for hepatitis C. The US Preventive Task Force followed suit in 2019, CDC in 2020, and then finally, the American College of Obstetrics and Gynecology and Society for Maternal Fetal Medicine just changed their guidelines this year. And these last two changes in the guidelines are critically important because obstetricians, which include me, follow the guidelines from ACOG and SMFM. So now everyone recommends universal hepatitis C screening in every pregnancy. Next slide. Next slide. So why should we screen universally for hepatitis C? Number one, we're seeing, like I mentioned, increased prevalence of hepatitis C in pregnancy. Risk factor-based screening universally misses hepatitis C cases because providers don't ask about risk factors and patients often don't tell, and risk factors that identified, still hepatitis C tests aren't ordered. Pregnancy is a window of opportunity for testing because it's a time when women of reproductive age are engaged in care more so than perhaps any other time in their young adult life. It's very easily to implement because we're already doing a ton of screening in pregnancy, which include HIV and hepatitis B. And then identifying all the cases of hepatitis C can significantly improve outcomes for mom. We can talk about harm reduction counseling to reduce the risk of community spread. We can also link moms to care for hepatitis C. For the infant, we can do intrapartum transmission risk reduction, which I'll describe briefly in a few minutes. And then also we can know which babies we should screen for hepatitis C. And universal screening has been shown to be cost effective in several studies from several groups. Next slide. So I just want to briefly discuss how we assess infants for perinatal hepatitis C transmission. Unfortunately, there's nothing that we can do at birth. The earliest we can actually know about hepatitis C perinatal transmission is between 2 and 6 months if we get a hepatitis C RNA test. But the guidelines recommend that we really actually wait till 18 months and test with a hepatitis C antibody test. So there's a lot of time that happens between birth and 18 months. And then 3 years is the earliest we would consider treatment of hepatitis C in infants. But unfortunately, screening for perinatal hepatitis C only occurs in a minority of infants. Only 11 to 30% of infants are screened for hepatitis C, and this is that were perinatally exposed, and this is critically important gap that we really need to address. Next slide. So are there interventions that we can use to decrease the risk of perinatal hepatitis C transmission? Perhaps lessons from prevention of perinatal HIV transmission. What about elective cesarean delivery before the onset of labor? There's no randomized study, but the meta-analysis that we do have showed that there was no change in the transmission rate. Therefore, cesarean section does not appear to reduce the risk of perinatal hepatitis C transmission. What about avoidance of breastfeeding? There are studies that show that there is actually no hepatitis C RNA found in the breast milk. And then clinical studies have shown that there's no transmission of hepatitis C from a risk between breast and bottle feeding. Therefore, it is recommended that women with hepatitis C be able to breastfeed as long as if their nipples are not cracked or bleeding. So what do we do? What do I do as an obstetrician to prevent perinatal transmission? We avoid invasive procedures like fetal scalp monitoring, amniocentesis, operative delivery, but frankly, as an OBGYN, I do not do those interventions without significant indication. So there's really nothing that we can do. Next slide. What about treatment of hepatitis C during pregnancy? So back in 2014, direct-acting antivirals were FDA approved. It really revolutionized hepatitis C treatment because these medications are orally administered for 8 to 12 weeks. They are very well tolerated, and they provide greater than 95% cure rate. So what are the arguments in favor of treatment? Treatment of hepatitis C during pregnancy would reduce postpartum loss to follow-up by treating women at the time when they're engaged in prenatal care and have insurance coverage. So treating during pregnancy will increase the rate that pregnant women are treated for, or women are treated for hepatitis C. It also might reduce the risk of perinatal hepatitis C transmission to the infant. And children we know infected with hepatitis C through maternal to child transmission develop cirrhosis at an earlier age than children who acquire infection through other routes during childhood and are also at an increased risk of hepatocellular carcinoma. So this may significantly improve outcomes for children. And surveys indicate that a majority of women with hepatitis C would be interested in treatment during pregnancy, particularly if it could reduce the risk of perinatal hepatitis C transmission. Now, the arguments against treatment are that we have very little data on the safety of this strategy and the safety in breastfeeding. So next slide. So we conducted the first study of hepatitis C treatment in pregnancy with a medication called ladipasvir. This is a 1 pill once a day treatment for 12 weeks. It only treats certain types of hepatitis C, genotype 1, 4, 5, and 6. So about a third of people have genotype 2 or 3 infection in the United States. So this strategy would not be appropriate for people with those other types of infection. So we recruited participants over a 2-year duration. This recruitment process was extremely challenging. We screened 29 participants. We had 20 screen fills. Half of those were, again, due to genotype 2 or 3 infection. We enrolled 9 participants. After the participants were enrolled, we had 0 loss to follow-up. And that includes their infant, which we followed for an entire year after birth to see if there were any adverse effects of the medication exposure during pregnancy. I do want to pause to note that the use of ladipasvir and any of the direct-acting antivirals during pregnancy is not currently recommended except in a research trial. Next slide. So the conclusions for our study. In this first study, we really wanted to get an idea, because of all the physiologic changes in pregnancy, whether or not we needed to adjust the dose of the medication for pregnant women. And we found that there were any changes in the drug levels in the blood of pregnant women that compared to those that were in non-pregnant women. So we do not need to do a dose adjustment. Very importantly, all 9 of our participants were cured of hepatitis C. Okay, so we had a 100% cure rate. And we also found that we did not find any significant adverse outcomes in the pregnant women nor in their infant due to the study medication, due to ladipasvir. So we're currently doing, because of these reassuring findings, we're currently doing a study evaluating a pan-genotypic regimen, meaning specifically valdiserri that can treat all types of hepatitis C, and we're actively recruiting that study right now in Pittsburgh. But what we really need is larger studies to be conducted to really confirm the safety and efficacy of hepatitis C treatment during pregnancy. Next slide. So during our hepatitis C treatment study of those 9 participants, we asked each participant what they thought about treatment during pregnancy. And I want to share with you some of the quotes. One, they said, "I think I'm a bright thing, and this treatment for hepatitis C is a clean start." Another said, "I'm ecstatic, grateful. I don't know, kind of proud that I went through something and accomplished it." And another said, "I'm down to like barely detectable. I think it's definitely going to help me not want to keep using or relapsing or using, because it's been such a process trying to cure it." And then another participant said that this is life-saving. So Our participants in the study said that hepatitis C treatment during pregnancy increased their self-esteem, their sense of well-being, and it might also be protective against relapse. Next slide. So if our goal really is hepatitis C elimination, then we really must look at every opportunity to test and treat for hepatitis C, and this includes during prenatal care. For women of reproductive age who have hepatitis C, we see higher rates of substance use, poverty, trauma, mental health disorders, incarceration, poor social support. So we can't expect this population to go to their postpartum hepatology referral. We really have to integrate hepatitis C treatment into prenatal care and also into addiction treatment. And really, hepatitis C elimination will not be possible unless we have the option to universal test for hepatitis C during pregnancy and immediately treat. Thank you so much again for the opportunity to speak, and I'm going to hand it over to Julie.
Good morning. So yes, thank you, Catherine. I'm going to speak about preventing perinatal hepatitis B transmission. And this is intended to be an introduction to the topic. And I do not have any conflicts of interest to disclose. After this presentation, participants will be able to understand hepatitis B serology and transmission, what are perinatal and chronic hepatitis B infections, basic facts on hepatitis B epidemiology, recommended methods for perinatal hepatitis B prevention, and how public health plays a role and approaches this issue. First, let's review tests for hepatitis B that will be referenced in this presentation. First, we have the hepatitis B surface antigen, or HBsAg. A positive result is an indicator of chronic infection. It is also present during an acute infection. Hepatitis B surface antibody, or anti-HBs, is an indicator of immunity to the hepatitis B virus. It is present after resolving infection or after vaccination when the result is greater than 10 units. Then we have the hepatitis B E antigen, or HBeAg. When positive, this correlates with high levels of viral replication and infectivity. Finally, the hepatitis B virus DNA. It is present when the virus is replicating and most often measured quantitatively to determine a patient's viral load. The higher the viral load, the greater the risk of transmission and damage to the liver. Hepatitis B can be spread from person to person when infected blood, semen, or other body fluids enter the body of someone who is not infected or immune. Examples when hepatitis B transmission can occur include birth to an infected mother, sexual contact with an infected person, sharing needles during injection drug use, or sharing other items like toothbrushes, razors, or other sharp instruments with an infected person. On the other hand, hepatitis B is not spread by sharing food, water, utensils, kissing, coughing, sneezing, or breastfeeding. Transmission does not only occur with direct human-to-human contact, as the virus is very hardy and remains infectious on surfaces for up to 7 days. A bleach solution is suggested for sanitation purposes. So, perinatal hepatitis B infection is acquired from a hepatitis B infected mother in a child less than 24 months of age. It occurs during delivery, mostly, though rare cases can occur in utero. Hep B infections in young children in general are mostly asymptomatic, so a diagnosis of perinatal hepatitis B infection relies on testing the child. Without any intervention, like the vaccine, the immune globulin, the risk of infection depends on the Hep B E antigen and the Hep B DNA status of the mother. The risk is approximately 90% if the mother is E antigen positive, and 5 to 20% if the mother is E antigen negative. The most important risk factor for perinatal infections is the maternal HBV DNA level and is associated with mothers who have very high levels of DNA. Now, up to 90% of perinatal infections become chronic, compared with approximately 5% of adult infections. That's why it's so important to prevent the infection in newborns and in infants and young children. So for chronic hepatitis B infection, this is the inability of the immune system to clear hepatitis B after infection. And it is defined by, or can be, diagnosed by hepatitis B surface antigen positivity greater than 6 months. Now, most people have no symptoms, but can still spread hepatitis B. And so testing is also really important. 25% of people who develop chronic hepatitis B infection during childhood will die from serious liver disease like cirrhosis, scarring of the liver, liver cancer. This is referred to as hepatocellular carcinoma. Sorry. Though no cure for hepatitis B is available, the goal of treatment is to achieve undetectable levels of virus. So if the viral levels are low, this helps to reduce transmission and disease progression. Now let's take a look at the epidemiology of hepatitis B worldwide, in the United States, and among pregnant patients. Worldwide, there are approximately 292 million people living with chronic hepatitis B. This is almost 4% of the world's population, with 880,000 deaths per year due to hepatitis B-related cirrhosis and liver cancer. Perinatal Hep B transmission accounts for 50% of global chronic hepatitis B burden. The geographic distribution of chronic infection is shown on the world map to the right, and shading represents prevalence rates measured from high to low, where high is represented by the darkest shading and low is represented by the lightest shading. The regions of sub-Saharan Africa and parts of Asia, including China, have the highest prevalence. This is greater than 8% of the population in those countries and regions, whereas the United States and most of the Americas have a low prevalence of less than 2%. In the United States, it is estimated that between 850,000 to 2.2 million persons are living with chronic Hep B infection, and of those, approximately 70% are foreign-born. The chart on the right shows the estimated number of chronic Hep B infections per 100,000 persons plotted over time on the horizontal axis from 1980 to 2006. Historical declines in hepatitis B infections correlate with the introduction of the hepatitis B vaccine in 1986 and the CDC recommendation for the routine Hep B vaccination in children in 1991. Now you can see that's the blue line, whereas the red line shows the imported rate, which you can see has, it actually went, it's gone up and down pretty much. And that, fluctuates based on immigration and then also, worldwide vaccination efforts. Okay, so estimating prevalence of hepatitis B in pregnant patients in the United States is achieved using various data sources. Using a combined analysis of data from the National Survey and Haynes with seroprevalence data from other countries, as well as vital statistics data on maternal country of birth, the CDC estimates that 20,071 infants were born to hepatitis B infected pregnant patients in 2018, and that is their most current estimate. Several studies have observed declines in incidence in recent years. Using public health surveillance data in New York City, the incidence of births to hepatitis B infected pregnant patients per 100,000 live births decreased from 1,573 in 2006 to 1,329 in 2015. This was a decrease of 1.4%. Finally, based on laboratory data from Quest Diagnostics, one of the largest private national laboratory companies, a 77% decline in the rate of new hepatitis B chronic infections was observed among women of childbearing age, from 0.8 in 2011 to 0.2 in 2017. And that was a study by Tatiana Kushner. This slide and the next slide are from the hepatitis B, the perinatal hepatitis B surveillance data from New York City. So this shows the breakdown of race and ethnicity for hepatitis B infected mothers who delivered live births in 2020 in New York City. So 59% were Asian Pacific Islander non-Latino, 22% were Black non-Latino, 9% were white non-Latino, 7% were of another race ethnicity, and 3% were Latino. This slide shows the breakdown of country of birth for hepatitis B infected mothers who delivered live births in 2020 in New York City. Most notably, 45% were born in China, 19% were born in the region of Western Africa, and 5% were born in the US, with only 1% of the cohort with an unknown country of birth. Now I'll discuss methods for preventing perinatal hepatitis B infections. The most impactful strategy for preventing perinatal infections is incorporating a universal birth dose into the hepatitis B vaccine schedule. The following recommendation was most recently updated in 2018 by the CDC. For infants born to hepatitis B negative mothers with the birth weight greater than 2,000 grams and medically stable, providers should administer a hepatitis B vaccine within 24 hours of birth. Like most local public health jurisdictions, New York State, New York City does not have a public health law requiring a universal hepatitis B birth dose, but it is promoted as a best practice. Delivery facilities must adopt their own written policies. Vaccine information statements, which we refer to as VISs, are required to be given to the parents by law prior to the vaccination of the infant. Families do not have to provide consent, written or verbal, but they must be informed, and they may decline. Though all newborns are recommended to receive the birth dose within 24 hours after birth, infants born to hepatitis B infected mothers must receive the intervention of Hep B vaccine birth dose and the hepatitis B immunoglobulin, or HBIG, within 12 hours of birth. This must be followed by the Hep B second dose vaccine at 1 to 2 months of age. And the Hep B third dose should be given at 24 weeks. This is 6 months or 168 days, and it can't be earlier. Efficacy in preventing perinatal Hep B transmission when giving both Hep B vaccine and the immunoglobulin is 94%. Efficacy is 75% with vaccine alone and 71% with immunoglobulin alone. Post-vaccination testing must be conducted for infants born to Hep B infected mothers. They should be tested for both the hepatitis B surface antigen for infection and the antibody to see for immunity. They should be tested at 9 months of age and not earlier. And I'm just going to say that they should also be tested 1 to 2 months after the final dose, without going into the details there. Given that the hepatitis B vaccine series with the HBIG is not 100% efficacious, in recent years, studies have been completed and recommendations for hepatitis B DNA testing and antiviral treatment during pregnancy from relevant U.S. professional associations as well as the CDC have been published and are aligned as follows. Antiviral treatment for hepatitis B positive pregnant patients with HBV DNA levels greater than 200,000 international units per milliliter as an adjunct to the post-exposure prophylaxis of the infant has been associated with significantly reduced rates of perinatal Hep B transmission. All hepatitis B infected pregnant patients should be tested for hepatitis B DNA in each trimester. And then patients with hepatitis B DNA greater than 200 international units per milliliter that are not already being treated should be considered for initiation of antiviral therapy at 28 to 32 weeks gestation. Now I'll discuss the public health, the role of public health and the approaches. So the CDC Perinatal Hepatitis B Prevention Program was established in 1990 and provides grant funding to immunization programs at local health departments as part of a national strategy to conduct surveillance of hepatitis B in pregnant patients and to provide individual patient-level case management for infants born to hepatitis B infected mothers. The program consists of all 50 states, 6 cities, including New York City, and 6 US territories. The national program objectives are to identify hepatitis B infected pregnant and postpartum patients, and to provide education as well as medical referrals to mothers, preferably during the prenatal period. For the infants born to hepatitis B infected mothers, the programs aim to ensure newborn prophylaxis within 12 hours of birth, that's the Hep B vaccine and the HBIG, and timely completion of the 3-dose hepatitis B vaccine series, as well as timely and complete post-vaccination testing. To ensure complete identification and enrollment into the public health programs for the hepatitis B infected pregnant patients and the successful medical management of their infants, all pregnant patients should be tested for hepatitis B surface antigen, even those known to be chronically infected. So they should be tested for in every pregnancy. All hepatitis B infected pregnant patients should be tested for Hep B DNA to determine if antiviral treatment is indicated during pregnancy. All hepatitis B infected pregnant patients should be reported to local public health authorities in the jurisdiction where the patient resides. Reporters may include prenatal care providers, laboratories, delivery facilities. There can also be universal reporting methods, such as recording the maternal hepatitis B status on birth certificates or newborn screening requisition forms. Reporting methods may include paper or electronic methods, depending on the local jurisdiction. To ensure complete identification, New York State public health law mandates provider-initiated prenatal testing and reporting. In addition, in 2014, the New York City Health Code was amended, and it now requires that laboratories report pregnancy status on all hepatitis B positive lab reports that go to the health department. Laboratories can ascertain pregnancy status based on prenatal panels that include hepatitis B tests, namely the hepatitis B surface antigen. Also, if providers, when submitting laboratory requisitions, provide pregnancy-related ICD-10 codes. There can be pregnancy questions on lab requisition forms. And also, if a patient was admitted to the labor and delivery unit of a facility, the hospital laboratory should know that the patient was pregnant. Also, in New York State, the maternal hepatitis B status is recorded on the newborn metabolic screening form, which is a universal reporting method, given that all newborns are tested for the various metabolic disorders. In New York City, we've also used enhanced surveillance methods where we compare different data sources, such as comparing birth certificate data using maternal identifiers and comparing that to laboratory, hepatitis B laboratory data. We've also looked at the completeness of the data that we obtained from the newborn metabolic screening program. So once hepatitis B infected patients are identified and health education is provided, in New York City, they are referred to another New York City Health Department program in our Bureau of well, it was the Bureau of Communicable Disease, which actually just recently changed, but the viral hepatitis program is still intact, and they provide patient navigation for hepatitis B patients, and they've been providing this navigation for the patients that are from the perinatal program, and they help to link them to care for further testing and evaluation for treatment, and that's prenatal and postpartum. So in summary, hepatitis B continues to be a significant public health problem worldwide. Chronic infection is associated with lifelong morbidity and mortality. The US incidence of hepatitis B has declined dramatically, but prevention of perinatal hepatitis B infection remains critical. The majority of hepatitis B positive patients are foreign-born, though in recent years, we have seen an uptick in acute hepatitis B infections linked to the opioid epidemic in US born. So the combined prevention approach of universal hepatitis B testing of pregnant women, universal hepatitis B birth dose, vaccination and testing of infants born to hepatitis B infected mothers, and antiviral treatment of pregnant patients when indicated is a very effective combined approach in preventing most infections. Multiple surveillance strategies, including laboratory and provider reporting to local public health, as well as a universal reporting method in each jurisdiction, should be used to identify hepatitis B in pregnancy. Local public health also should conduct case management and patient navigation to ensure vaccination and testing of the infants born to hepatitis B infected mothers and proper evaluation of the pregnant women, as well as the postpartum mothers. Thank you.
This is Ron Valdiserri again. I want to thank both of our speakers for excellent presentations. We certainly have time for Q&A. Now, I want to remind the audience, if you have any questions, go ahead and type them into the Q&A box, and we will strive to answer them as time permits. I'm going to begin, Catherine, with a question to you. And that is, a question came in asking, what are, in your experience, what are the barriers to screening all pregnant women for hepatitis C once they enter care? And do you have any thoughts about interventions that could be put in place to address these barriers?
Yeah, that's a great question. I think the most significant barrier recently was the lack of ACOG support for universal hepatitis C screening. And now that that's come through, I think that we will see a lot more health systems moving towards universal hepatitis C screening in pregnancy. In my health center at UPMC, we implemented universal hepatitis C screening about a year ago, and we basically added the hepatitis C test to the OB panel. So that is a slew of tests that are recommended for anyone entering prenatal care, like rubella, IG, like hepatitis B, surface antigen, et cetera, syphilis, HIV, just added hepatitis C to that, and that really increased our screening. The other thing is to have reflex testing, and what I mean by that is having the screening test, hepatitis C antibody test conducted. If it's positive, then the sample will automatically be tested for active hepatitis C infection with hepatitis C RNA test or viral load. So those are the kind of more structural things that can be done. That's a great question.
Thank you, Catherine. We're going to ping pong back and forth here. Julie, I have a question for you. You might want to come off mute. This is an opinion question, but I was struck by the fact that you indicated that New York City has the requirement that all laboratories report pregnancy status when they're reporting positive hepatitis B tests. And I'm sure you're familiar with a recent publication from CDC talking about the National Hepatitis B Perinatal Prevention Program. And one of the comments that they made there was that many laboratories across the United States do not report pregnancy status when they report a positive hepatitis B test. And that, of course, is what triggers public health action. So the question from your expert opinion, how important is it to make sure that laboratories report pregnancy status when they're reporting a positive Hep B test?
So it's really important for the perinatal program to do the work while the woman is still pregnant in terms of the education, the referral. We even, I didn't mention in this talk, but we even refer the household contacts for testing. The initial source of report is usually the laboratory, because the providers in general, well, it takes longer for the provider to get the result, but also many providers don't report prenatally. Delivery facilities are very good at reporting, and we only have 39 delivery facilities, whereas there's hundreds of prenatal care providers. So it's easier for us to enforce reporting at the delivery facilities. But if we just look at all sources of report, not including laboratory reporting, then we just actually recently analyzed the data. Only 35% of our cases are getting reported prenatally, not if it wasn't for laboratory reporting. And then the reverse is true, that 65% of our cases are getting reported prenatally, including when you include the laboratory reports. So that's a huge difference.
So I will insert an editorial comment for those advocates who were on the webinar that working with clinical laboratories and commercial laboratories to help ensure that pregnancy status gets reported when there's a positive Hep B test would be a great step toward improving identification of pregnant moms and infants who are at risk. So I'm going to go back now to you, Catherine. We have a couple of questions related to the very important issue of treating pregnant women for hepatitis C during pregnancy. And let me see if I can break this down. Generally, the person is asking, how much more data do we need to be able to say that it's safe? I mean, you clearly made the point we don't quite have enough data now. And this person is also asking, is there any retrospective data that might be useful, short of randomized controlled trials to look at it? I mean, I guess generally I would say if you could talk about the future and what we need to do to be able to say yes or no that this is safe and effective. It's a big question, sorry.
Yeah, it's like $1 million question.
I know, it's $1 million.
That's what a lot of people have asked. First of all, I think any data is helpful. I think that retrospective, data like that we might get from the antiretroviral pregnancy registry, if we expanded to include hepatitis C direct acting antivirals, then that would be helpful. It would be supportive. We need some prospective clinical data. Whether or not we're ever going to get an indication or a label change for any of the DAA regimens is, I think, unlikely. But frankly, there's a lot of medications that we use in pregnancy that are off-label. So really the goal, I think, is to get enough data to make obstetricians or infectious disease doctors or hepatologists or family medicine doctors comfortable enough to treat in pregnancy. So how many pregnant women in a study is necessary? I worry about a randomized controlled trial. We know these direct acting antivirals are effective in treating hepatitis C and theoretically should prevent perinatal transmission. And so is it ethical to randomize to treatment during pregnancy or treatment after pregnancy? A lot of people say, I'm worried about that it's not ethical. Therefore, we should do a more of a prospective cohort and compare outcomes to a historic control. I think that's the better design. So hopefully in the next 3-4 years, we'll at least have 1 and maybe 2 studies evaluating valpatisivir sofosbuvir in a larger cohort in pregnant women.
Thank you. That was a very useful response. Julie, I'm going to go back to you. This is a New York City question. I think it would apply also to the West Coast of our nation. But given the fact that you showed in your presentation that most of the pregnant women who in New York City who are hepatitis B infected and giving birth are foreign born, I wondered if you could just talk a little bit about the experience of how does the health department work with community-based organizations and maybe social service providers who are providing other services to these women to be able to help you folks do your job in preventing perinatal Hep B transmission?
Okay, that's a very good question. I would say that most of the work that's done with the community-based organizations is through the viral hepatitis program, which is, not in the Bureau of Immunization, but we benefit, the perinatal program benefits from their work through the Hep B Moms program, which is that patient navigation program that I was talking about. So there's a program called Check Hep B, and it's a New York City Council funded program that provides funding for hepatitis B testing and treatment, and different community-based organizations can apply for grant funds. The Charles B. Wong Community Health Center has been longstanding awardee of that funding. There's also African Services Committee, and then there's a Korean Services Committee, or that's not the exact name, but it's similar. Anyway, there are a number of different, there's also now not just the different community-based organizations, but several of the hospitals as well that have large immigrant populations that they serve. So I think New York City, continues to work on this issue, and has, we also have a hepatitis B coalition that has a number of different community-based organizations. So, but most of that work is being done out of the viral hepatitis program that we do benefit from. I would say one thing though, in our program, we have a number of bilingual staff that, provide culturally sensitive health education.
Thank you. Yeah, we all know about the issue of silos in medicine and public health. We have to be able to work across them. And I guess just stating the obvious point, based on my longstanding roots in HIV prevention, public health needs to work closely with non-governmental organizations to be able, and the private sector to be able to achieve its goal. Catherine, I'm going to come back to you. I actually have a question, but I first want to respectfully disagree with something you said early on in your presentation. Namely, you were making the point that there is currently nothing that we can do once a woman with hepatitis C is pregnant. And I agree with that, but I'd kind of like to go upstream and say that if we're able to identify women who are infected with hepatitis C and cure them before they get pregnant, then from a public health point of view, that's, I mean, I know that's harder to achieve, but it is an acceptable way to prevent transmission. So that's kind of the slight disagreement I had with you, but I want to bring it back to the important point you made about integration, about being able to integrate hepatitis C services into like substance abuse treatment, into other social services, which is a strategy to kind of reach women before they become pregnant. So I don't know if you just have general comments you'd like to share with that. I know it's not easy to do, but I think we would all recognize that it's a goal worth trying to achieve.
No, Ron, I completely agree with you. So the way that I look at it is that we have to use every single window of opportunity to to test and treat. I mean, and there can't be lags between testing and treatment, because that's when people fall off. And so, while they're incarcerated, while they're in rehab, while they're present for prenatal care, while they present for Pap smear, any opportunity to test for hepatitis C should be supportive, and then immediately treat, because we know that the loss to follow-up rate is high. It's significantly worse in the postpartum period, I'd say. We tried to do a study here in Pittsburgh of postpartum treatment of hepatitis C, free treatment and paid visits. And we had about 50% that enrolled that we just lost to follow-up. And it's a very high-risk time for drug use relapse. If anyone's had a newborn at home, it's a significant stressor, I'd say. So it's not the ideal time for treatment. And that's why I argue that prenatal treatment during antenatal care is perhaps a better time.
So we just have literally 3 minutes left. And I do want to remind everyone on the call that a recording of this webinar will be posted on the HepVu.org site later on this afternoon. So if you have colleagues and friends who you think would benefit from hearing from our two outstanding speakers, please push it along. But I'm going to give first Julie and then Catherine just a chance to say something. Julie, if there was one thing that you could do, if you were Queen of the United States and there were one thing you could do to improve the efforts to prevent perinatal Hep B transmission, what would that be?
Wow, that's a big question.
I know it's big and you don't have much time.
No, I mean, I think that, the laboratory reporting is very important for identification, getting women into care. And so funding is needed for laboratories because they can't do it on their own. That's the thing, is that they need the funding to actually make the changes in their limb systems. But then also, having a reflex of if it's a Hep B test positive in a pregnant patient, they should reflex to DNA, universal birth dose, really working on those policies.
And I think I'm going to stop you there. And I think that the important point you've made is that we have to do a better job nationally investing in electronic systems that make it easier for labs to report, that make it easier for clinicians and public health practitioners to get that information.
Yeah.
So, Catherine, Julie has been deposed as Queen of the United States, and now you're Queen of the United States. What would be the one thing would be at the top of your list to improve or prevent? Let me say prevent the transmission of hepatitis C from moms to babies.
Well, I think everyone's going to know my answer, but we have to test for hepatitis C universally in pregnancy, and then all active hepatitis C cases must be treated during pregnancy. That I believe would eliminate hepatitis C transmission. Yeah.
Well, listen, in closing, you can't hear from the audience, but I'm hoping the audience is giving both of you a great big round of applause because you've both covered two very complicated issues in a short amount of time. And we really, at HepVu, really appreciate both of you making time to share your expertise with us. So I'm going to go ahead and close. It's noon. Thank you both, Catherine and Julie. Thank HepVu for organizing this. And by all means, participants, check out hepvu.org for more information about viral hepatitis in the United States. And happy World Hepatitis Day to everyone. Adios.
Thank you.
Thank you. Bye.
Bye-bye.